So welcome to this event, Drug Politics from AIDS to COVID-19. My name is Sean Jacobs. I'm an associate professor in international affairs at the New School. My guest is Achal Prabhala. I'll introduce him properly in a couple of minutes. He's the coordinator at the Access IBSA project. Before we start, I'd like to just read some housekeeping rules. Firstly, this event is being recorded. Please use the chat window for general conversation. Use the Q&A feature throughout the event to send questions to the speaker. You'll have the options to ask questions anonymously. The moderated Q&A will take place after the presentation. And then finally, you can follow us on social media after the event at newschool_IA. You can also follow us on Facebook. Just look for the Studley Graduate Program in International Affairs. That's where you can follow us. So just by way of introduction then, this event is presented by the Julian J. Studley Graduate Program in International Affairs at the New School, at the School of Public Engagement at the New School. It is part of a series of events, which is titled Decolonizing International Affairs. It's a lecture series, a lecture and panel series, and it's organized by our program. And as you can see, there are 2 more events in the series next month, The Problem with Economics, with 3 young economists, Francisco Perez, Ingrid, former New School graduate, and Grief Chelwa, who's based in Zambia. And then finally, we have an event, the Global Movement for Black Lives, on April 6, 2021, with 4 panelists, 1 from Brazil, 1 from the US, from the UK, and from South Africa. So as some rich countries grapple with the shortage of COVID-19 vaccines, and many poor countries worry about getting any at all, the role of pharmaceutical corporations, and specifically their monopolies on drugs and vaccines, has come under scrutiny again. The problem with access to COVID-19 vaccines today traces its roots to the AIDS crisis that engulfed South Africa 20 years ago. The world has designed a system that saves only the richest of us. The rest of us are consigned to suffering and worse. If a global pandemic won't change us, what will? Our guest today is Achal Prabhala, public health advocate and campaigner. He's the coordinator of the Access IBSA project, which campaigns for medicines in India, Brazil, and South Africa. Achal is also a leading commentator on vaccine politics. In fact, I would recommend a couple of pieces that he has written in the New York Times and the Guardian over the last few days and months, as well as an interview he did on Democracy Now! In his most recent article, co-authored with Chi Yok Ling, a Malaysian public interest lawyer who worked on improving access to medicines in China, Achal and Chi argued that it is time to trust Russia and China's vaccine. And they argued that they too work, these vaccines from Russia and China, and they can help fill shortages everywhere. So Achal will speak first, after which we will have a Q&A. Achal, over to you.
Thank you very much, Sean. Thank you so much. I'm so happy to be here. This is actually the second time I'm speaking, the third time I'm speaking at New School, the second time in the pandemic, and I'm really grateful. Sean and I are also friends, so that makes it even sweeter. Thank you all for being here. I really appreciate it. I am going to start by showing you excerpts of a film that I'm in the process of making. It's a film that is directly tied to the subject of today's talk, which is how the mess we're in with coronavirus vaccines today was a very predictable event, and in fact is very similar to events that happened around the world, which were given less media attention, but nevertheless caused immense suffering and heartache over the last 20 years. It starts in South Africa, and this is the connection between what we're facing today and what millions of ordinary South Africans faced in 1999. I'm going to share my screen. I'm going to play you 3 or 4 little clips with explanations in between, and then we'll get into what the story means for us in the present day. Thank you for indulging me. That little clip is from archival footage that was carefully curated over the years by a group of people who surrounded a really remarkable campaign that began in South Africa in 1999 called the Treatment Action Campaign, which honestly shook the world. This campaign has a lasting legacy that we can feel up to this present day. The model of activism that they pioneered and the template for gaining access to life-saving medicines like vaccines was really something that they invented for the very first time and then successfully spread across the world. So what happened after 1999 in South Africa is over the years, many other countries began to realize that they had exactly similar concerns and they started taking action too. So here's the second clip. We'll get into that. One of the things that you might have noticed there is that the demographics of people protesting for access to life-saving medicines switches suddenly in around 2015 from being something that is happening in tropical countries, in poor countries, to Black and brown people, to white people in very rich countries. This is a shift that I'd like to talk about more when we finish, when you finish seeing the very last clip that I'd like to show you, which is where we are now with access to medicines. This is work, as I said, from an ongoing film that I and a large team of people are in the process of making. But here are a few recent segments on where we stand on access to vaccines for the coronavirus around the world. Thank you. Thank you for bearing with me. That's it. There are no more clips to show. So I'd like to begin where the clips that you saw just began. In 1999 in South Africa, it turned out that millions of people needed miraculous HIV medication that had come to market in the United States in 1996. So 3 years before the Treatment Action Campaign was formed, AIDS had turned into a manageable condition, a chronic condition like diabetes, something really unremarkable that could be treated, that could guarantee anyone who had been infected with the human immunodeficiency virus a very normal life. But the problem was that it came at a cost. It came at a cost of $10,000 a year. And that meant very few people outside the United States and Europe could afford it. Tragically, the treatment came to market in the United States as a result of the work of an immense cadre of dedicated activists from organizations like ACT UP, AIDS activists, the very first generation of them, who are captured in a beautiful film called How to Survive a Plague, which if you haven't seen, I'd urge you to. It's really one of the most remarkable films I've seen. And I'm actually working with the person who made that film, David France, to make what we hope will be a sequel to How to Survive a Plague, which is what happened to that miraculous antiretroviral therapy once it came to market. Zaki Ahmad was one of a number of people who discovered that he was HIV positive at around the same time. And at around this time in the mid-1990s, what the world discovered at the same time as discovering a treatment for AIDS was that the largest number of people who needed this treatment, where the infection was, in fact, was outside the United States and Europe. It was in sub-Saharan Africa, it was in parts of Asia, and it was in parts of Latin America, all regions of the world with incomes that were much, much lower than Europe and the United States, which meant that individuals could barely afford this medication at $10,000 a year, let alone their governments, especially in countries like South Africa and Botswana, where the prevalence of this disease was so high that Government budgets would simply explode if they had to treat people at that cost. Zaki Ahmad was a remarkable, brave individual who decided to take his life into his own hands and fight for it. He decided that life saving medicines, if they existed, were his right to have and were the right of every South African who needed them to have. This is a really remarkable thing because prior to this, there were so many ways in which poverty creates death. I mean, quite literally. The idea of there being better treatment available somewhere else or better medical facilities available somewhere else, I think was something that people had always known. But to have as stark a situation as a treatment that existed, that literally meant the difference between life and death, that you couldn't have simply because you couldn't afford it, was something that was really the genius of the treatment action campaign to articulate and explain to people and to make them believe in the fact that they too had a right to do this. I'm from India and I'm speaking to you from Bangalore in India. And I think one of the great overlooked features of modern day South Africa is that its biggest export really has been democracy. Perhaps I think if you live in the United States or Europe, in more functioning democracies in a certain way, the spirit of South Africa is something that can be overlooked. But if you come from a more tired democracy like India, or from another country in the African continent, let's say in West Africa, which had become independent prior to South Africa, it's a feeling that you recognize instantly when you arrive in South Africa to work, as I did after I finished after I finished my college education. Sean and I have a common friend called Antone Jabe, who's from Cameroon and runs a beautiful art and literary outfit called Chimurenga in Cape Town. And one of the most remarkable things he ever said to me was, the thing about South Africans is they really believe in this democracy. He's French. And it was a remarkable thing to say because it was completely true. And that's also exactly what I felt. There was a feeling that you believed in your government. You believed in the idea that what was just and right should be yours. And you believed in a system that would work for you. And it was quite a shock because I certainly didn't have that feeling ingrained in me growing up in India. And Ntone certainly didn't have that feeling in him growing up in Cameroon. But it was a feeling that infected us being in South Africa. And I think the spirit of the movement to gain access to these medicines, which was eventually successful after a huge and tragic death toll in both South Africa as well as sub-Saharan Africa, where uh, hundreds of thousands and millions over the years finally died as a result of waiting for this treatment. The spirit of activism to gain control over their lives infected the entire world. What also happened was that it turned out by about 2005 and 2007, when pharmaceutical companies who were making these antiretroviral medicines found that they simply could not monopolize these treatments any longer. Their systems of intellectual property had created complex international webs of monopolies that meant that they were the only producers of these medicines. They didn't have to be, but they had the legal protection to be the only suppliers. And that meant that they could charge whatever they liked. That meant there was very little negotiation that was possible with them. But they too found eventually that the outrage that was spreading across the world at their uh, incredibly callous and tragic behavior, uh, their complete lack of responsibility for human life, meant that they could not continue business in this manner. And so they changed course as well. And this is, by the way, the same industry that in 1997 decided wisely to sue the government of Nelson Mandela. A pharmaceutical industry executive was asked a few years later, after the US government withdrew its support for the suit against the government of South Africa for trying to make a tiny amendment in its law to allow for the import of cheaper medicines, as to why the pharmaceutical industry thought it was a good idea to sue Nelson Mandela in the first place. And he said, look, we had to. Mother Teresa was already dead. And it was a black joke. It was black humor. It was being funny. Unfortunately, there was nothing funny about the chilling effect that the actions of the United States government, of the global pharmaceutical industry on South Africa had, not just in South Africa, but on other countries. They were doing was to send a signal to South Africa and other countries to say that to tamper with the system of monopolies that tremendously benefited Western pharmaceutical corporations and governments would be to invite all manner of legal action, of trade sanction, of any number of bilateral disputes that would be sure to make the lives of any government that resisted them absolute hell. Nevertheless, the spirit of activism was so strong that it spread. In India, we discovered that we had the opportunity to make a new patent law, which we did in 2005, and I was involved in those efforts. A new patent law that said we can't give away as many monopolies as we do to pharmaceutical companies because most of them are really unjust and undeserved. So, of course, immediately there were multiple attacks from a range of different countries and by one company, Novartis, which was trying to dispute the their or rather assert their monopoly right over a drug called imatinib, which was a key and really sort of miracle treatment for chronic myeloid leukemia, which is a deadly form of cancer, which to which the Indian government had denied them a monopoly. They fought that case. They fought the Indian government. They tried to have our patent law overturned and challenged the Indian government over the course of about 10 years until about 2013, when the Indian Supreme Court finally ruled that Novartis had no case, that Indian patent law would stay just as it was. It spread to Brazil, where by the late aughts, hepatitis C, which is often described as a silent killer, became a less silent killer. It was something that people discovered had high prevalence, not just in Brazil, but other parts of Latin America, all over Eastern Europe, in countries like Ukraine. And Gilead discovered a fantastic drug for hepatitis C called sofosbuvir, which they brought to market in about 2008. Again, with just one little catch that it cost $84,000 a year, a price that was so outrageous at the time that even in the United States, mainstream newspapers like the Washington Post devoted headlines to the price of this drug. You had this infection, hepatitis C, that was deadly, that had no treatment up to that point. You suddenly find that there is this miracle treatment for hepatitis C, except it costs so much that everyone is wondering how they can afford it. There were again a range of different campaigns in Brazil, in Eastern Europe, to try to gain better access to this drug. Gilead proved to be a remarkably resilient company that withstood an onslaught of outrage and still managed to ride that out to the extent that the price of sofosbuvir finally never really dropped to the level it should have, which meant that there were thousands of Brazilians who continued to die because the national health system in Brazil, which is a very well funded health system when the Brazilian economy was doing well, even so couldn't afford to buy enough of the drugs to serve its own citizens. But what was really remarkable is that by about 2015 and 16, the kinds of things that I had been working on, as I said, which were primarily in Black and brown countries, in poorer countries, in middle income countries, suddenly became a global problem. The United States discovered that insulin, the most commonly taken medication by people with diabetes, had all kinds of pharmaceutical monopolies around it because of the fact that minor improvements had been made to the way that the insulin was produced and delivered. And all of these had been monopolized, which meant that the price had shot up into absolute unaffordability. Sexually active gay men who use something called PrEP, which is a combination of antiretrovirals that you can take to almost entirely reduce your risk of infection from unprotected sex, suddenly found that the cost of taking PrEP was in the thousands of dollars every month. as opposed to a couple of hundred as it was in countries like India, which meant that it was simply unaffordable, even to middle class Americans who wanted access to PrEP. In the United Kingdom 2 years ago, I was very surprised to discover that in one of the richest countries in the world, in one of the best funded health systems in the world, the National Health Service, a drug for cystic fibrosis, again, a pioneering drug, one of the first drugs that had a proven effect on reducing the effects of what is otherwise a debilitating and deadly problem that affects very young children, came to market, but the NHS couldn't afford it. And so they couldn't buy it. And so hundreds and thousands of families with heartbreakingly young children who needed access to this drug could not get it. I joined uh, in tandem with a group called Just Treatment in the United Kingdom. I worked with a group of activists who were representing parents of children who needed or can be the cystic fibrosis drug developed by a company called Vertex. We went to Argentina and discovered that there was a generic version available there for 1/6 of the price outside of Vertex's monopoly. We created a buyers club so that parents of children who needed the drug immediately could access the drug at a relatively affordable price from a foreign country, while petitioning the government at the time, a conservative government, to take over the patent, because governments have had that power always. Governments have an incredible range of powers when it comes to regulating pharmaceutical monopolies. The tragedy is that they haven't often used them. Anyway, faced with a general election in the UK 2 years ago, faced with a, an almost national outrage in the United Kingdom, where the most right-wing newspapers in a very right-wing media were carrying the story of how children with cystic fibrosis were dying as a result of the NHS not being able to do its job, resulted in Vertex finally caving. They offered the drug to the British government at a price that they could afford. And exactly 2 years ago to this date, they began rolling it out to the young children who needed it. What was remarkable about that movement, however, was the transformation of this problem. For many of us, I think, who live in third world countries, who have experienced the, the brunt of United States and European trade expansion policies, the free trade agreements, or the different kinds of bilateral deals that these companies make, has been so incredibly harmful that, in a way, I suppose we've believed all this while, I believed all this while, at least in the earlier parts of the last 2 decades, that somebody must have been benefiting from it. And clearly, it wasn't causing a problem to the Western countries themselves. So I think the prevailing idea was that everything is fine in Europe, everything is fine in the United Kingdom, things are perfectly fine in the United States, even though there's no, even though there isn't a nationalized system of universal healthcare. Because obviously, we don't hear people complaining that much, and so they must find other ways to afford these drugs. It's us who are really suffering. That changed significantly when we discovered that the people who are benefiting from this system is even smaller than we had thought. Even middle class people living in the richest countries on earth were sometimes suffering from a lack of access to drugs. They were also at the receiving end of pharmaceutical monopolies, like we had been for 20 years. And this actually was a good sign for the access to medicines movement. For anyone who was concerned about access to medicines in India or in South Africa or Brazil, it was a very, very positive sign that activists in the United Kingdom no longer had to be merely advocates for their fellow citizens in other countries, in poorer countries, but could join the struggle as being fellow victims of the very same monopolies. And it meant that the outrage was more universal, the outrage was more global, and that the outrage was happening at the very heart of the countries that had created these policies, that had unleashed them upon the world, causing all of the suffering that we've experienced over the last 20 years. This is the backdrop to everything that had happened before we went into the coronavirus pandemic. And so naturally, when we did, having understood how the pharmaceutical industry operates, having understood how monopolies kill people, because that's really what they do, there was a lot of concern about how treatments at first, in the early stages of the pandemic, and then vaccines would be brought to market. And this concern was very justified on two counts. One, on price. Uh, we worried that the price of some of these vaccines would simply be beyond the reach of poor countries and lower income countries everywhere in the world. But the second problem was supply. None of these pharmaceutical companies had ever created a product that potentially every single person in the world needed. There were global diseases, sure, hepatitis C, HIV and AIDS, a range of different cancers. Obviously, people across the world gets them, but nobody had supplied a situation where we had a problem which everyone needed a cure from. The vaccine, of course, is not a cure. The vaccine is prevention and protection. But we were very, very concerned that the system of monopolies would create these shortages in supply, which would mean, again, that there would be two reasons why poorer countries wouldn't be able to access vaccines at the same time. We hope that it would be something better than what happened at the turn of the century. South Africa had to wait 10 years after antiretroviral therapy had been developed in order to get before they got it. And certainly in the pandemic, for poor countries, for lower income countries, even for middle income countries, to wait a year or 2 years or 3 years, we're talking not only about an incalculable loss of human life, but also uh, losses to the economy that are just staggering, where every day, every month just means a scale of misery and deprivation that almost no other kind of disease has been able to wrought before. And so it was of burning concern that the question of pharmaceutical monopoly regulation be addressed. Those pleas kind of fell on deaf ears. And so where we are now in February 2021 is that we have a range of vaccines that have been developed in the West, primarily the Pfizer and Moderna vaccines, and then the AstraZeneca vaccine. These vaccines were given a range of different financial incentives by primarily the European Union and the United States. They were given incentives in this manner, money to actually produce the vaccine. So Moderna, for instance, which had never made a single pharmaceutical product in its life, was given a $1 billion research grant that 100% covered its costs on research and development. So meaning, even if the Moderna vaccine had failed, it was covered. It was literally like receiving insurance in advance. They were given money in what are called pre-orders. So this is like a prize. Pfizer was given up to about $6 billion from the United States and Europe. Moderna was given another $1.5 billion from the United States. And this is all initially, these countries have all ramped up these orders extensively since that time. But essentially, they were told, bring a vaccine to market, have it approved by our regulators, and you get this prize. You get $1.5 billion from us. Pfizer, you get $6 billion from the United States and Europe, simply for bringing a successful vaccine to market. So not only had they had their research costs significantly covered going into their vaccine development, at the end of their vaccine development, they had a massive pot of gold awaiting them. But that wasn't enough. So they wanted a third protection. And the third protection was all the traditional monopolies that they typically enjoy. So not only do they have their research costs covered, not only do they have these huge pots of gold awaiting them in order, but they also had this global monopoly on the patents, on the intellectual property that covered their vaccines, and on the technology that was used to create those vaccines. So vaccines had two layers of monopoly protection, making them sort of, doubly deadly as, let's say, antiretroviral drugs for AIDS, for instance. And they made sure that they exercised all of those incentives and those monopolies. AstraZeneca did a little better. AstraZeneca created contracts in India for a company to produce 1 billion doses in 2021 to supply other low-income countries. They've run into other kinds of problems, of course. But what's essentially happening in the West now is that there is a shortage of supply. There is a shortage of supply, a documented shortage in the United States. It's described every single day. The moment any state, like New York, for instance, just a couple of days ago, opened up and increased access to vaccines by allowing more groups of people to be eligible to receive a vaccine and immediately plunged into a shortage. The European Union has done particularly badly. As of last month, they had vaccinated something like 2% of of their population. In fact, they were so concerned about the supply of vaccines to them, despite having funneled billions prior to the emergence of these vaccines, that they created an export ban on AstraZeneca vaccines. So what they said was that if there is an AstraZeneca vaccine being produced in Europe that is not for us, we have to approve where it's going to, because we're so concerned about the fact that for some reason, pharmaceutical companies were sending them much less vaccines and much less supply than they needed than to the other rich countries they had promised vaccines to. So that's what's happening in rich countries, not working out very well. Middle income countries, meanwhile, there's been a really interesting turn that you would almost be excused for not having understood or seen at all because it has so little coverage in Western media. Sean spoke of an article that I wrote with my colleague in Malaysia, Chio Kling, on the Russian and Chinese vaccines. What we did was we examined the data on them and found that, in fact, other than a murky set of politics and geopolitics and prejudices, they work fine and that they should be considered seriously. You won't actually see any reflection of that in any Western media article on vaccines because they are not considered seriously. However, every middle income country in the world has taken them seriously and has placed multiple orders for them. There are two leading Chinese vaccines. Sinovac is a private pharmaceutical corporation and they have a vaccine called CoronaVac. Sinopharm is a government operation, and they have a vaccine created at their Beijing Institute that is at a very advanced stage and is out in the world in a number of countries. Russia has a government-funded project from a very respected biotherapeutics research center called the Gamaleya Center and the Russian Sovereign Wealth Fund, the Russian Direct Investment Fund. Their vaccine is called Sputnik V, and they've put that out and again marketed it across the world. Every middle income country, from the Arab nations to the majority of countries in Latin America to a large number of countries in Asia, Malaysia, Indonesia, Morocco, Egypt, Jordan, Argentina, Brazil, Turkey, Bolivia, all of these countries have orders for millions and millions of Russian and Chinese vaccines, and that's how they're going to get through the pandemic. In the United Arab Emirates, which started vaccinating with the Sinopharm vaccine on the 14th of December, so in pandemic time, in the Paleolithic era, 2 million people have already received the Sinopharm vaccine. Many of the countries that are at the top of the pyramid when it comes to the number of people and the percentages of people vaccinated have done so through Russia and China. And yet, a large part of the world pretends like these vaccines don't really exist. And then finally, you have lower income countries. These are poor countries. They're called many different kinds of things. They're called least developed countries. They're called low income countries. India is what's called a lower middle income country. So the terminology is horrifically confusing. But lower income countries are typically both poor and lack industrial infrastructure to participate in the vaccine manufacturing process, which puts them at a double disadvantage. They have absolutely no guaranteed vaccine supply and are almost wholly reliant on an organization called Gavi, the Vaccines Alliance. Gavi is working with the WHO, the World Health Organization, and CEPI, which is the Coalition for Epidemic Preparedness and Innovation. With great fanfare, last year, they announced that they would be in charge of saving the world. And that plan hasn't been going so well because at the end of the first quarter of 2021, by March, they hope to ship out 130 million AstraZeneca vaccines and 1.2 million Pfizer vaccines. So that's 131 million doses of vaccines, which would, I suppose, vaccinate about 65 million people, but to 145 countries. So the number of vaccines that any of these lower income countries is going to get from Gavi is so small that it's almost going to be insignificant. But that is their only supply of vaccines at the moment. That's the way the world is, and it's not a very happy picture at all. I think that it is incredibly sad and frustrating as an activist, despite having worked right through this pandemic, to discover that the situation is not as bad as we had imagined. It's worse. And if there is any ray of hope in this mess, that is the global rollout of vaccines for the coronavirus and the management of this entire situation, it is that even the richest countries in the world are not doing that well in the pandemic, who are not actually getting as many vaccines as they need, and that there seems to be a growing shared understanding across the world, rich, poor, and in between, that it might finally be time to rein in this unfettered system of granting legally sanctioned monopolies to pharmaceutical companies and pretending that that's in our best interests when it hasn't been for the last 20 years, and it absolutely certainly isn't in the most significant health catastrophe that the entire planet has ever experienced in at least 100 years. So I'll stop there and hand it back to Sean, and hopefully have now a more free-flowing discussion on some of the points I raised.
Thank you very much, Achal. That was great. Actually, I was typing away because people have been sending questions. You've sort of alluded to some of them, and in others, it would be great if you could kind of respond to them. So I'm going to just ask the first question because I think it seems that this is something not just in today, but in general, this is a burning question that people have. So I'm going to combine these questions and let me just read them out and you answer. So the first question is, let me start by a comment from Autumn Herndon. They ask, governments have the power to take over patents. Why don't they use it? In what cases, if any, have governments used their power to take over patents in the past? And I know you started talking about South Africa. And what factors influenced them to do so? And then related, Shreya asked, what would happen if non-Western, so I think this is sort of alluding to like a strategy, or lesser developed countries organized under, say, BRICS, band together in a form of activism, resisting big pharmaceutical global influence, pressure, and address the supply and demand requirement appropriately without flooding the market with unrequited or wasteful solution. And then just the last one to this is, Sakiko, our colleague Sakiko Fukudopar asked, why aren't countries like Thailand, Colombia, South Africa using compulsory licensing to manufacture vaccines themselves? In other words, I think the big question to all of this is like, what is the real obstacle in the supply constraint? Like, what is it that prevents these countries from doing this?
Yeah, all great questions. So let me start with talking about why countries don't take the law into their hands more. Firstly, they're members of the WTO, which is the World Trade Organization, and the World Trade Organization created a global regime for these intellectual property monopolies, which means that if you go against the law, against their rules, then you are potentially in danger of losing your trading privileges. And losing trading privileges is basically ceasing to exist. So intellectual property monopolies have been weaponized by placing them at the heart of the World Trade Organization, which is why India and South Africa made a proposal at the WTO a couple of months ago to suspend intellectual property monopolies in the pandemic. A majority of developing countries agree with them. Over 100 countries agree with them. But a handful of rich countries, the usual suspects, including Brazil, so the United States, the European Union, Japan, Brazil, have resisted it. And because the World Trade Organization works by consensus, it means that it stays resisted. It's not a proposal that will easily pass. But to get to the question of why countries don't use the law, it is not against either what you've agreed to at the World Trade Organization or against your own law or against your constitution to issue a compulsory license to take over a patent, which is what we were asking the UK government to do 2 years ago for this cystic fibrosis medication called Orkambi. The reason that rich countries don't do this is that they've never done it. They've threatened it when they needed it. So the United States threatened Bayer, which was a company that made an antibiotic called Cipro. In the aftermath of 9/11, there were threats of a widespread anthrax attack in the United States, and they needed a huge quantity of ciprofloxacin, and they threatened Bayer with a compulsory license, which made Bayer drop their price and marshal a whole range of other manufacturers in to give the US government more supply of Cipro. But there have been very few instances of it actually being used. And in part, that's because the pharmaceutical industry is such a potent force in funding the campaigns of people in the Senate and in the House, in being such a big pillar of the economies of the European Union or of the United Kingdom, of being such a linchpin in those countries' economic strategy that to go against them would be, has been presented at least to the elected governments of these countries, like cutting off your own arm. It is not, of course, and they are holding them hostage. But it is a happy hostage situation where so far governments have been really more than willing to comply with every new outrageous demand of the pharmaceutical industry. Now, in poor countries, there has been actually much more action. There are countries who've issued compulsory licenses, including India, including Brazil, including Thailand, including Cambodia, including a range of countries. Now, every time they do that, however, they are subject to these extreme sanctions, to these bilateral disputes that are raised by the United States and Europe, which have serious consequences. So the only countries who have successfully got away with it are countries with enough economic and political clout where the US or the EU cannot ride over them quite as easily as they would to a smaller country. So it is something that is done even by these countries quite rarely, because it does create a situation which invites this backlash, which no one wants. And it's only something that can be done by countries of a certain size. You know, when it comes to vaccines, there is a way in this pandemic where we cannot legislate our way out of them. With antiretroviral drugs, we just needed countries to act by enacting what was already in their law. So they could literally legislate their way to access. If South Africa passed a compulsory license, or if India did that, then manufacturers could produce that drug, supply it, deal done. With vaccines, there's a really interesting problem, which is that vaccines have two kinds of monopolies on them. One is the intellectual property, which can be legislated, but the other is actually the technology transfer, the process of creating that vaccine itself, which sometimes includes even just the original biological material that is used to create the vaccine. This is sort of complex, but is a monopoly that has been created by the pharmaceutical industries, where really only the original process and the original biological material serves as evidence of a working vaccine, where copies of that vaccine are not considered to be testable, meaning that it isn't, um, according to regulatory authorities in the world at the moment, if I create a vaccine from scratch that behaves exactly like another vaccine that they've approved, I cannot demonstrate that equivalence very easily. I could do that for antiretrovirals. I cannot do that for vaccines. So unless I want to go through the entire phase 1 to phase 3 clinical trials, which are very expensive and take time, I have to have a license from them that says I'm using the same technology, I'm using the same cell lines, I'm using the same hamsters, or whatever it is that created the biological material. And then I could put my vaccine out. And so it requires the cooperation of these companies as well to transfer that technology and share it in order for these vaccines to come up. There's an underlying question there about Russian and Chinese vaccines as well, but I think that is another question we should get to when we do.
Well, you just on that, because you sort of said in your answer that it's only countries with enough economic and political clout that can withstand this kind of present order. So you are saying it can only be Russia and China?
No, not really. I was talking about medicines in general over the last 20 years. So, in terms of Sakiko's question about compulsory licenses, or I think it was another person's question about why countries are not using compulsory
Yeah,
licenses.
that
So,
was
one
a
is that
Kiko. That was a Kiko. Yeah.
there is a limitation on what compulsory licenses can do in the pandemic because we're talking about vaccines, which require compulsory licenses plus another kind of cooperation in order for them to be replicated. But and there is blowback when you use compulsory licenses. And what I was saying in reference to the blowback when you use compulsory licenses for AIDS drugs or cancer drugs is that the only countries who have been courageous enough to do them are the ones who have the economic and political clout to get away with them. So, in fact, actually, that's not Russia and China, weirdly. That's places like India, that's places like Thailand, it's places like Brazil or South Africa. These are the countries who've either threatened or used compulsory licenses and have then manipulated the countries who did try to give them some degree of grief over this with the outpouring of public opinion in their support and the fact that they themselves are economically and politically significant enough to stand on their own feet.
Okay, so a related sort of this kind of it's more like a related follow-up question, I suppose.
Yeah.
Elena Katarsevich wanted to know about the appointment of Dr. Ngozi Konjo-Iweala as the new Director General of the WTO, and how would you interpret that? Is that a good? I know you've been on a program with her recently on Al Jazeera. Is that a good move here, like in terms of real possibility for change at the WTO, especially with regard to suspending, in Elena's words, certain provisions of TRIPS?
Oh, I wish I could say yes. uh, I really admire, and I should just say that, Dr. Okonjo-Iweala, I think, is a special person. I actually admire her ambition, and I really do respect her career in some fashion. I think that she is probably aligned in a very different way from the way I am, or any of us, or you are. Uh, and I think that there are a couple of things working against her favor. The executive position at the WTO is it has some power, so it's not completely powerless. You have power to affect things like procedure, you have the power to affect the tone of the organization. But that I think is also dangerous because I think that what it can do is to provide a very PR friendly 21st century face to an organization that still works on mid 20th century global principles of how the world should be. So the WTO really is an organization that, to say that it's captured by the richest countries in the world would be to say that somehow it was set up differently and was captured by them. It is an organization of the richest countries in the world that's run by them for their purposes. That's really it. The member countries have a say, have the only say in what the WTO does. The WTO, the head of the WTO, could really wish whatever she liked. That would not happen unless the richest member countries, which is to say the US and the European Union, wanted it to. It doesn't succumb to any amount of political pressure or public pressure or global outrage. It's happened before, it'll happen again, it'll happen now. That's not going to change the way the WTO works. So I think that there are some public perceptions of what Dr. Okonjo-Iweala's ideologies may be, and who she's aligned to, and the kinds of organizations she's worked with. She was the board chair of Gavi prior to her appointment to the head of the WTO. And I have significant disagreements with the way that Gavi has functioned. I think that she isn't responsible for Gavi's actions, but I think, unfortunately, in the same way, she will not quite be responsible for what the WTO does or doesn't do when it comes to things like the India and South Africa proposal.
Right. Just related to that, why Lindsay Myers wants to know why. I mean, you said Brazil is opposing the proposal put forward by India and South Africa. Why is Brazil opposing the proposal by India and South Africa to the WTO? Is it because of Bolsonaro? Is it deeper?
It's not entirely clear. It's actually quite a good question. So I think the obvious answer would be Brazil is a country run by a deranged lunatic, and therefore it is doing something that is deranged and lunatic. But I think that it's not entirely clear because of the fact that Brazil has often occupied a very odd position in this pantheon of countries like even a formation like BRICS, for instance, or IPSA, or any of these pan third world formations that Brazil has been a part of, it occupies the oddest position in that group because of the fact that its own policies, much like actually South Africa, are more closely aligned with, I don't know how to describe them better, as Western values than maybe even Russia or China. Um, which means that Brazil has, in conjunction with South Africa, always been something of an outlier. Uh, the Brazilian regulation system believes that it works better and has a higher standard of regulation than India, let's say. There's definitely been long-standing suspicion of the quality of Indian drugs in Brazil. So there, I think the best answer would probably be a combination of these two things, maybe an emboldening under the Bolsonaro regime, but also a very long-standing tendency in Brazil itself to be on the side of the richest countries on earth, partly because that's how it identifies itself, or that's what its aspirations are. Interestingly, of course, 1 month after they opposed the proposal to suspend monopolies, Bolsonaro wrote a letter which was then immediately splashed gleefully across the front pages of Indian newspapers, I'm sure much to his disapproval, to Prime Minister Modi asking for an emergency shipment of vaccines, which was sent. And so, other than Sinovac, which the state of Sao Paulo has tested and trialed, approved, and then is now vaccinating people with, the vaccines that are being delivered to healthcare workers in other parts of Brazil or by the federal government, which Bolsonaro is in control of, are emergency shipments that have been sent from India. So, Bolsonaro's opposition to this TRIPS waiver is egregious, not just because it is something that is hurting us, but it's also something that's hurting him, and he's clearly acknowledged it.
Okay, so here's a question from Becca Rosales. What needs to happen for Gavi to ensure the equitable access of vaccines globally when wealthy nations who fund it are against lifting intellectual property rights for COVID vaccines and treatments?
So Gavi is a really interesting organization. Gavi was set up 20 years ago in order to get vaccines to poor countries. So that was Gavi's mission 20 years ago. Vaccines themselves, by the way, have been thought of in in a not very good way as being magic bullets of the sort of development industrial complex. So, and what I mean by that is that there are hard things that are unsexy that can be done in order to make health systems and health function better and be better in poor countries. And those are things like expanding the infrastructure of health or creating better delivery systems, increasing the number of doctors and nurses and healthcare workers, etc. These are typically the kinds of things that you cannot show success of in neat PowerPoint slides on an annual basis. Vaccines, however, are the exact opposite of that. You can actually show an incredible outcome for whatever you put into sending vaccines to X poor country. And therefore, Gavi came into the world at a time when many of the countries that were pouring foreign aid into poor countries wanted magic bullet type results. They were more satisfied with them. Politically, it worked better for them. And I think ideologically, it also just felt cleaner and more efficient and as though they were getting more done. However, in the pandemic, Gavi has turned itself into an organization that it's not, which is an organization that is also serving rich countries. So Gavi's model was to raise money from rich countries and then spend it in poor countries by buying vaccines for them. In the pandemic, Gavi decided, as part of this COVAX facility, that what they would do is to take both rich countries and poor countries as clients. So they would buy vaccines for everyone, and that they felt would give them more leverage. They would have more money to spend, they would have more negotiating power. That worked out badly. They don't really know how to service rich countries, and they made many serious missteps. They said right at the outset last year, one of the more egregious things they said was, they said poor countries would get a maximum of 20% of their populations vaccinated through them, and they would have to justify that through paperwork. They would have to justify the population of healthcare workers, people with comorbidities, and senior citizens. And then Gavi would ship them that prescribed quantity. Whereas, If you were a rich country who was paying for vaccines through Gavi, you could just let Gavi know what percentage of your people you want vaccinated, which seems like a very odd way of running a service, which has a first class cabin and then an economy cabin, right? Actually more like first class and third class. So that they walked back, and then they walked it back yet again and put it back in, and it's still unclear how that's going to work out. But the real problem with Gavi is that they've never had to compete for a vaccine that rich countries actually want. So their bread and butter and the kinds of vaccines that they've been putting out, for the most part, were vaccines for meningitis or measles or tuberculosis. These are vaccines I take, our children take them here in India. No one takes them in Western Europe. No one takes them in North America. As far as I know, many of these vaccines, like for tuberculosis, people don't take because these diseases have been eradicated for so long that they're not necessary. So Gavi has never been in a situation where it's trying to buy vaccines at a time when rich countries are. So imagine this. Gavi is going to a pharmaceutical company like Pfizer to say, hey, I know you have only 10 of these vaccines or some very short supply, but I want to buy large quantities of these vaccines at a discounted price, while you have countries like Israel who are willing to pay up to 2 times the price of your vaccines. And I know that, and I know that other countries are trying to buy these vaccines for full price as well. But I still want you to give me a large quantity at a lower price for the poor countries on my list. And surprisingly, that is not working out very well for Gavi. And the results of that are that they are going to send uh, really what can be described as a trickle of vaccines into the poor countries they serve by March, months after 20% of Israel has been vaccinated, nearly 20% of the United Arab Emirates has been vaccinated. You'll have, less than 0.5% of some countries being able to be vaccinated through the supplies that Gavi sends them, and it's just no solution.
Which just leads me to a quickly related question, because I want to ask this, a quick other series of questions I want to ask. But just on this, Sakiko, just as a follow-up, asked, will the vaccines from China and Russia pressure Big Pharma and Western governments, I'm assuming Gavi, to shift their position on India's South Africa proposal at the WTO, or will it lead to COVAX rethinking its strategy?
This is such an interesting question, Sean. And you and I have talked about this a little before, and I would love to speak about this some more. I think, Sean, you linked to the article that I wrote with Yokling in the Times. If any of you watching this haven't read it, I would urge you to read it, because it is seemingly counterintuitive, though it shouldn't be. We wrote this piece, which was entitled with the headline we didn't write, but which we agree with. The headline is, "It's time to trust China's and Russia's vaccines." At the time that we wrote it last week, when we published it, it was intuitive to us from our perspectives. I think the kinds of bodies you have and the locations in which those bodies are located inform your experience. In my case, it was going to a small fishing village in the United Arab Emirates over the New Year and passing a place, I've forgotten what it's called now, but in Dubai, where every single day, thousands of cars lined up to receive the Sinopharm Beijing vaccine, which was being disbursed by the government and had been for the last 2 weeks before we had got there. To see one of the richest countries in the world give out this vaccine in these incredible numbers, and to see people taking it there, this was something that they did after running trials in the United Arab Emirates. It really changed my perspective of what these vaccines were. I don't come from the United States or a rich country, so when I look at, let's say, what Brazil is doing, or Turkey is doing, or Argentina is doing, that's a sign of approval for me. These are countries with highly regulated health systems, with GDPs per capita that are much, much higher than India's. And so in many ways, these are countries whose examples we try to emulate and look up to, which I think is different if you come from Europe or the United States. So all of these countries have approved a vaccine from Russia or China. They have all started giving these vaccines out. Yet, there is an astonishing level of backlash we received for writing what I thought was a purely factual article about the data on these vaccines from China and Russia, it's important, I think, to separate the science of these vaccines from um, justified criticisms of the state, whether it's actions against minorities like Uyghurs in China or people who are gay and lesbian and trans in Russia. These are all real things that these states do. However, and this is the hard part I think that we have to grapple with, is that does not affect the quality of the vaccines that come out of these states. Sometimes by organizations like Sinovac, which is a private pharmaceutical company, which is not a part of the state. I have no trouble, for instance, dissociating the Pfizer vaccine from an expansion in the occupation of the West Bank, even though both those things were authorized by the same person. I don't think of vaccines as from the United States as somehow associated with the odious nature of Ivanka Trump or Jared Kushner. And I think other people should be able to make those distinctions as well and evaluate these vaccines for what they are. They are really ambitious projects. Obviously, Russia and China know what they have and they know what they can do with them to be able to put themselves into a new place in the world. And they are doing that. But I think that whatever the motives are for why these vaccines are going out, honestly, if I personally read one more article about what's it called, vaccine diplomacy, actually, I feel I'm just going to, faint and keel over because we're talking about a situation where countries are being locked out of vaccines. The Pfizer and Moderna vaccines, they're nearly 100% of the supplies of that vaccine over the next year have been promised to rich countries. No one else has access to them. And in that kind of situation, for countries who are doing deals to get vaccines as best as they can, there is no shame. Who cares, what the diplomacy angle of this is? I care about where these vaccines are going and what they're doing. And so far, the evidence is that the Russian and Chinese vaccines not only work, but that the manufacturers of these vaccines are really interested in getting them out. So as much as possible, they'll supply from Russia and China, but they're willing to make deals for these vaccines to be produced elsewhere. So they're willing to give licenses that in fact break away at the monopoly that they have on their vaccines. They're producing them in Brazil, they're producing them in the United Arab Emirates, in Turkey, in Kazakhstan, in South Korea, in India. And this is very much the way you want the world to work. These are the best shot that low-income countries have in terms of gaining access to a vaccine. Now, they're enmeshed in another kinds of politics as well, which is, I think it's taken the world about 20 years to understand that maybe you can have copies of quality drugs and vaccines made in India. I think that the idea that you can have an original vaccine that works against the coronavirus that was developed outside the West is something that's just blowing the minds of many people, because how can that be possible? Apparently, not impossible to me. It does not sound far-fetched in the least. Apparently very far-fetched to the rest of this world. And there is a huge enabling system that makes that perception harder to swallow because you have so few original products developed outside the West. And there's a reason. There's a whole infrastructure of medical regulation that promotes this idea that it's really only Western countries who are capable of either producing these products or approving them. So the WHO, for instance, which is an organization we all love and are not meant to criticize, is something we did criticize in that op-ed and therefore got slammed for as well, is they have taken over 6 months now to evaluate the Chinese and Russian vaccines, despite them having come into the system much before many of the Western vaccines. And then for the Pfizer vaccine, they took 6 weeks to evaluate the Pfizer application from start to finish, and they approved the Pfizer vaccine 10 days after the European Medicines Agency approved it. This kind of treatment is not available to vaccines from outside China, from the West. And it is exactly the kind of system that enables this perception. I think that's now slowly going to change. The vaccine shortage is going to force people to reckon with the Chinese and Russian vaccines as viable alternatives. I hope that happens. And I hope that it rearranges also just the pharmaceutical map. Indian generic AIDS drugs were a kind of epochal change in the way we thought of the global pharmaceutical system in 2000. The fact that you could have drugs made for $350 a year that cost $10,000 a year in the United States really fundamentally rearrange the world. And I think that coming out of this moment, if we can think of Russia and China as being, and possibly India, by the way, and Cuba, and a couple of other countries who are developing their own vaccines as well, as also being originators of pharmaceutical products that can save our lives, that will mean a huge step in the future going forward.
So I just wanted to like recognize or acknowledge, I think it was Funmi Tujuso and Sophia Navarrete-Zur who sort of asked questions, which I think you just answered. But related to that, I want to quickly ask this question by Melissa Bukuru. This is kind of related, not so much to the hesitancy around in the West around Chinese and Russian vaccines, but she's saying, how do we reconcile the narrative around vaccine hesitancy, i.e., that people, and particularly Black and brown people, don't want to get vaccinated or fear the medical system? And then she says, in some instances, it's often, maybe it's about fear or questions that people have about the medical system, but in other ways, it's also that people of color are less likely to have gotten their first shot, that there are barriers to getting access to the COVID vaccine website, signing up, which has nothing to do with people getting vaccinated. Like, do you want to comment on that?
Because I think I'm not somebody who works in that specific area, it's hard for me to comment on how we can overcome hesitancy, for instance. It's something that many people are concerned with, and rightly. I think that one way in which that could be done is by forcing vaccine manufacturers to release more data. There's been some criticism of the Russian and Chinese vaccines, but in fact, and I think this is something we try to address in this article, is that there's a fine grade of difference between what the Russian and Chinese vaccine manufacturers have released and what the Western vaccine manufacturers have released. So typically the system is quite opaque. If you are producing a vaccine, you really only by law need to convince the drug regulator that your vaccine is safe. That's the only institution to which you have to show your sort of full data. You don't have to release a shred of information to the public if you don't want to. Typically, many vaccine manufacturers do. But I think that if there were better ways they could release even more, there'd just be more of a public discussion around it. That itself might not solve hesitancy, it might even increase it because there'd be more questions that were asked, but it would at least be a more transparent system. I think what's really interesting in that question is this idea of who gets a vaccine. The WHO came up with something called the Equitable Allocation Framework some time ago, and their scheme is roughly the same thing that every country that's giving out vaccines is following, which is that you have three highest risk groups: healthcare workers, people who are over 65 or who otherwise qualify as senior citizens. The demographics of India means that this is people over 50. Because when you get to people over 65, the percentage is so low that it isn't worth considering on its own. And then people with documented comorbidities that affect your mortality under the pandemic. These groups, an average is that they would constitute 20% taken together of any country's population, right? I think that one thing that some of these groups miss, or people who work on models to create the best way to equitably allocate vaccines, the thing that they miss, I think, is poverty. This is not a direct answer to the question, right? And I think I'm, again, ill-placed to talk about why maybe African-American communities in the United States might have a greater degree of difficulty accessing a vaccine or hesitancy. But I think that the thing that strikes me is that poverty is one of these comorbidities that should be included that is not, which is to say that people who are also extremely vulnerable under the pandemic are people who cannot afford to either isolate at home in any reasonable fashion, or who cannot afford to not work in an environment where they are faced with much greater risk of infection than somebody who is not as poor. And it is a little surprising, I think, that in the way countries who are allocating vaccines have decided to, it is not a category that I've seen given any attention to. It's usually just from a more classical epidemiological model of risk, which is again, age and health and being in the healthcare system itself. And I think if you were to bring in poverty and take that seriously as a comorbidity, which is what it is, I think you would end up with a more realistic allocation model that would work to protect the most vulnerable people in any country.
So let me ask you the second last question, which is a combined question. Vanessa Crawford wants to know, how do people mobilize, because we talked about countries, to create a social movement, to call out big pharma, the WHO, and governments to create outrage about COVID-19 vaccine access, and just sort of to help, just to sort of comment on that. We've spoken about how the AIDS movement was a mass movement. The AIDS movement in South Africa was a mass movement. It's interesting that the COVID-19 movement is not a mass movement. And then the second part of this is Georg Wiegratz wants to know, why is it that the negotiations around vaccine orders and prices, etc., that this stuff is sort of secretive? Like, how can activists and researchers like follow this so that people, in the same way, I suppose this is what I'm saying, like there's a movement, but there's also, in the same way that, for example, the TAC, the Treatment Action Campaign at that time, was kind of directly, they were intervening directly in the discourse and, if you want, in the negotiations around prices. Like, why isn't those things, why aren't these happening, and where are those movements?
This is an excellent question. And I think that the most empowered people in this pandemic, and I really mean this truly, are American and European taxpayers. You are the most empowered people in this pandemic because it's your money that created these vaccines. All of the Western vaccines were made with your money. And you, therefore, are an owner of these vaccines. And I think if taxpayers in the European Union and the United States and Canada and Japan behaved like owners of the vaccine, right, and took a little control of it and wrested it away from being something that only three people in America can talk about. There is, I think, both this sort of intensely pyramidical medical dialogue around the vaccines, but then there's also an an intense concentration of people who dispersed that money and created all of these contracts that are not transparent, who are then seemingly these unquestionable czars in who have created these vaccines, right? But that entire system can be questioned. There are activists who are questioning it, but I think not enough. A part of the reason they're not questioning it enough, I think, is that what's been sold to the United States and Europe is this idea that we've got you, you're taken care of, right? Yes, yes, yes. All we could have done stuff to make sure that we got you, and we didn't hurt the chances of people in sub-Saharan Africa from getting these vaccines. So that could have been done, but they don't say that. But they say, well, we didn't. But anyway, we've got you. But the thing is actually that they haven't got you, right? They really haven't got you. And I think that that is something, I think, that could be a stepping stone to figuring out not only how, if you're an American taxpayer or a European taxpayer, you've not got what you've deserved, but also no one else anywhere in the world who had to be denied a vaccine on your behalf, right? Why that happened? Why did your government use your money to give you a vaccine at the expense of someone else? Because they didn't have to. They really didn't have to. They could have set up agreements where they were funding these vaccines for you in the United States and in Europe, and freeing the technology, not even taking responsibility for it, but just freeing it, allowing for other people to make this vaccine in poorer countries so that they could get it there, right? On the basis of these monies that were being given out to these companies, which was a lot to take care of people like yourselves who had paid for this. So I think that that realization, maybe when it comes to the fore and is more widespread, will create some kind of bigger public reaction. But there already is, there are large pockets of outrage about this, both with the domestic situation and the international situation.
So here's the final question. It's not about the politics of the vaccines, but it's about your film. Vanessa Crawford wants to know, can you talk about the documentary and what the process has been like, and when can people expect it?
I'd love to talk about the documentary. Yeah, it's the only thing I've been working on, actually, until the pandemic came along. We started it a year before the pandemic. And the way it started was just this. I've been working as an activist now for access to medicines for 18 years, and I think I fundamentally failed. And by that, I mean, everyone else, I think, who've been working on these issues has also failed to some extent. It's not a popular issue. When you talk about this, honestly, my parents, they live 5 minutes away from where I live. I love them very much. They love me. I don't think until the pandemic, they fully understood what I did. I genuinely don't think they understood it. They thought it was important and worthy. They thought I should be paid more. They were surprised I was working so hard and earning so little. They had really no clue. And it's really only in the pandemic that they've understood it. I think that people have done a very bad job explaining what this immense problem is that they've been suffering from. I've spent my life fighting for it, and I think it's very important. And so I should have done a better job at explaining this to other people. The reason I made this film, I want to make this film, is I've been working on it. I saw How to Survive a Plague, and I had not ever seen anything that was as touching, but also as artistically made as this film. They used archival footage. They used a very feature film style treatment in telling that story, and it was incredibly effective. It was not didactic in the way that I've thought of documentaries as being. It's not like, here's the message and let me stamp this on your head. And it really gave space to viewers to assimilate what was happening and make opinions themselves. And I respected that so much. So I got in touch with David France, who has since made several films and is now one of the United States' most renowned sort of highbrow popular documentary filmmakers. And we got together a small team, which includes a two-time BAFTA winner and a Peabody winner called Kolisa Sithole in South Africa, who's a documentary film director, who is the director of our film. Lauren Grunewald runs a production company in South Africa, which is helming the more organizational aspects of our work. I'm writing it and I'm producing the film. We started about a year ago. Work is primarily archival research. We're trying to unearth personal and institutional footage of the times from 1999 up to the present day. And then when the pandemic happened, I guess our film sort of got supercharged. We had to include it in some way. We hadn't anticipated it, but we had to include it in some way. And it gives, unfortunately, a tragic urgency to our film, which
Right.
I feel would have been relevant and would have worked regardless, but now has all the more reason to, because what was a sort of set of niche problems with AIDS in South Africa or hepatitis C in Brazil, or etc., is now a universal problem which we can address through a universal frame. We hope to have it out by the end of we hope to have it done by the end of the year, I think, and if all goes well, I very much hope you'll be able to see it early next year.
Achal, this has been great. I want to thank you very much for taking time out. I think it's very late in India. But yeah, this is
Only 2 o'clock. Only 2 o'clock.
You can't see all the people clapping.
Right.
But thank you very much for doing this. Thank you very much for the international affairs staff who's worked with us to make this possible. Thank you for those of you who tuned in. I know a couple of people had to leave already. This was really informative. It makes me want to join, to get more involved in global struggle rather than in my specific continent. So thank you very much, everybody. Have a nice week. Achal Prabhala, thank you very much for doing this.
Thank you. Thanks a lot. Bye. It was fun.